Okay, lab cases again from Asan Medical Center. Dr. Kang, can you hear me?
Yes, I can hear you.
All right, great. Would you introduce your cases? You will.
Good morning, Professor Nakamura, and good morning, Professor Fa. I am Dr. Do-Yoon from Asan Medical Center. This is my team, Dr. Jin-Ho Lee, our Senior Interventional Fellow, and Dr. Leo from Hong Kong, our fellow. And Dr. Leo, can you please present the case?
Sure. Good morning, everyone. I'm Leo from Hong Kong. First, I'll introduce our case. This is a 47 years old lady with a past medical history of hypertension. She was referred to Asan Medical Center for exceptional chest pain. A CT coronary angiogram was performed, showing severe stenosis of distal left main vessels. For her past medical history, she just had hypertension, no diabetes, no hyperlipidemia or smoking history. Clinical presentation with a stable angina, functional class 2. This is the baseline ECG showing sinus rhythm and no significant LVH or ST changes. This is the baseline chest X-ray, no cardiomegaly and no pulmonary congestion. We have done some non-invasive studies, including echocardiogram with normal ejection fraction, no regional wall motion abnormality with trivial mitral regurgitation and tricuspid regurgitation. The treadmill test was negative up to 6.1 MET. Other non-invasive studies were unremarkable. So we have done the cardiac catheterization, showing severe stenosis as a left main bifurcation with a mild stenosis at proximal RCA. This is the CT coronary angiogram, which shows the short left main with a severe stenosis. And this is the baseline coronary angiogram with minor disease over the right coronary. And this is the left coronary. From the left side is the AP caudal view showing the significant left main stenosis, and the cranial view shows unremarkable for the mid and distal LAD. This is a spider view showing the distal left main stenosis associated with the LAD and SIRT disease.
Thank you, Leo. The patient is a young woman, 47 years old. She only has the hypertension, but she's a little bit obese with the BMI 33. So at the treadmill test, it was negative, but she could not perform adequate exercise, only 61.1 MET, and had typical effort aggravating angina, and CT showed very severe left main bifurcation disease. And coronary angio showed the same findings. So do you have any discussion point or just question or comment for this patient?
Very tight, main bifurcation disease and the short limb main. So, okay, Nakamura.
Actually, this is a very anatomically very interesting, but very difficult to decide how to do the stent. Actually, so far I know the V stenting, so maybe easy to do, but the V stenting, the clinical result is so worse. So maybe it's very difficult to, decide.
So how would you do that if you this case is yours?
Anyway, first I was
first.
Yeah, five.
Anyway, in the strategic Dr. Hahn, what do you do?
I think she is relatively young and has true bifurcation lesions, so I think the two-stent strategy, elective two-stent strategy is needed, of course, with IVUS guidance. But short main is one of the problems for PCI, but anyway, two-stent technique is necessary, and in this case, I prefer the Kühler technique, mini-Kühler technique.
Dr. Kyung.
Yeah, so this patient has a very short left main. Definitely, I think this has to be IVUS guided or IVUS guided, and also elective two stenting strategy would be my choice as well.
Any Dr. Jae-Hwan?
I have same opinion, and I maybe consider culotte or crushing technique for this case because LAD and circle size is similar, and angulation is a little bit acute. So I don't think V-stenting or something is not so good. So I prefer to choose culotte or crushing technique.
Dr. Yum?
Yes, I favor the upfront two-stand delete IVUS guide, and I will probably advise a mini crush. The one thing is the post-motion is a bit aesthetic. Maybe you need to have IVUS to see how an LD seems the post-motion stimulation, and the IVUS imaging is needed to define the distal landing with a better result, a good result.
Joo-Yeon? Dr. Kim?
Yeah, I would definitely go for two-stand technique with crush.
Soo-Hong? Right, we're going to have some opinions from...
Yes, I think the upfront two-standing with the decay cross technique or mini cross technique is available because of the very short left main and the two bifurcation reasons. I think that is right.
Okay. So, Dr. Kang, why would you do that, right?
Yes. Thank you for your opinions. I'm really happy that all the experts has the one opinion. And one is to use the intravascular imaging, and second would be the upfront two-stand technique will be needed for this severely diseased side branch of circumflex. And which imaging device would be better? We presented Optimus trial yesterday, and even for the left main bifurcation disease, OCT and IVUS showed a similar clinical outcome. However, in this situation with some osteal disease, very severe disease, I personally prefer the IVUS imaging because of the better imaging in the ostium. And upfront two-stand I planned actually, but because it has very short stand, we consider the V-stand or crush or culotte. But in CT image, I checked the CT before, and there was some left main. Maybe the length is about 3 or 4 millimeters. So before the angio and IVUS, I plan to do the mini crush technique because it's more familiar to me. Yeah, and because I like, and also I like it. The patient is prepared for the 7 French jerkin radial approach. And next, this is a spider view. And next, I wired in the circumflex, then LAD was not difficult. And because the hemodynamic stability is the number one priority in the left main intervention with this severe stenosis, I just applied 2.5 compliant balloon to circumflex and LAD. Next. Next. Okay, and this is the angio after balloon. And I also prefer the jockeying guiding catheter because you can approach the left main without damage. And we check the IVUS. Can you please show the LAD IVUS?
Great.
This is the IVUS pullback from the medial LAD, and diagonal branch is coming in. And the vessel size is about 3.5. And from the diagonal branch, the plaque begins with the intermediate stenosis and also continues to the proximal LAD. And this is the IVUS after ballooning, so lumen is a little bit dilated. And you can see the ostium of the LAD, size 3.6 or 7. And the opening of the circumflex is coming from 9 o'clock. Because if this is after ballooning, lumen is okay. So the patient is stable, and there's distal LAD. You can see that there's some room of the left main. It's short, about 3 or 4 millimeter, but still there is some room for some crush technique or other complex technique.
All right, we're going to confluent.
Yeah.
Exactly, main length, what do you think? By hours.
Can you please measure the IVUS of the carina and
Just the ostial part to
ostial, here. Yeah.
And
the length from the ostium to left main ostium. It's 3.5 millimeter.
3.5 millimeter, right?
Millimeter.
Okay, and then IVUS again for the circumflex. Would you show that?
Yes.
One? And then
Next
we'll
IVUS for circumflex.
discuss about that one.
Yeah. And before circumflex imaging, I want to emphasize one thing. You can see that there is a run of the 1-2. That is before nitroglycerin injection. At this time, the vessel size of the LAD was 3.0. But after NTG injection and take some time, the vessel was dilated up to 3.5. So I want to emphasize is that to give nitro at the balloon and before intravascular imaging evaluation, vessel growth. And this is circumflex pullback. Can you please show me again? As you can see in the angio, proximal circumflex is a little bit, has some positive remodeling with a large size. Here, just proximal to the OM branch.
Ostial
Vessel
part,
size is about 3.7.
big vessel, right?
A big vessel and no
However,
disease.
getting smaller here.
Yeah.
The meaning is some negative remodeling.
Yes,
Part of
definitely.
ostial part is almost a 3 or something, right?
Yeah.
More smaller.
And here is the left main,
All right.
with a very short.
Would you show us again ostial part of circum?
Yes, circumflex os.
Very
Can you please show the
ostial.
circumflex os?
Very ostial.
Yeah, stop. Oh,
Great.
Stop at
No,
those
no,
two.
no. Just before
Okay.
previous one,
다시.
right? A little bit
Here is
further.
the osteo. Yeah. And here's the left main.
Anyways, you have to 3O. You have already done the balloon inflation, and so,
Yeah.
however, initial based on the angiograms, you have to fix up the both artery. And so, what did you do there? Oh, very interesting. Very short.
With
Three.
Yeah. With this, I planned to do the mini crush technique. Yeah. I think that it would be better than simultaneous kissing stenting or V stenting. And also left main itself is diseased, so V would be not a good idea.
In fact, mini cross is possible. So you have to deploy the short stent for the circumflex ostium, and then the meaning is very short limb main. You may have some difficulties to crush yourself. So for particular these cases, angle is not too big. And so personally, I think it's kind of a SKS, right? So kissing stand. If we cannot make a long, artificial carina, using the short carina, 1 millimeter, 2 millimeter, I think is quite enough. So, all right, I would ask Dr. Hahn, what do you say? So after the IVUS findings?
Yeah, SKS is one of the options, but in IVUS, left main is not so big, so I'm a little bit concerned about the acceptance of 3.5 or 2 stent in the left main. So I prefer still minicular technique.
Right, minicular. What about the size of left main size by
Can you please
IVUS?
measure the left main size in LAD pullback?
Practical point of view, it doesn't, matter in terms of a diameter. It's almost a 4 or 5. 2 stand is just like an overlap is quite enough, right? At the beginning of bifurcation stand, we did many cases of SKS, kissing the stand. Issue is is a long carina. Use the 2 stand like this. We have to make a long carina. There are some tissue growing, and sometimes research is focused on that. And so, however, in case of a very short, carina, I think it's another option for that, right?
Also,
I have one comment.
Yeah, technically, SKS is much easier. Everyone can do.
But this patient is young, so despite of the recent advance in stent technology, but anyway, there is a chance of restenosis. And one of the weakness of SKS is the when you meet the ISR, it is very difficult to treat by PCI. So
Right. That's the
and
point.
in general, the 2 or 3 millimeter prolapse in the aortic ostium of the left main stent is acceptable. So I think the 8 millimeter push dilation balloon is possible for crushing in this case.
Chang-Wook,
Test.
Okay, after the IVC evaluation,
Okay.
I think it's this patient is very young woman, so I think it's a provisional approach can be another option actually with the DCB for circumflex. But yeah, anyway, if we can optimize with the two-stent strategy, their outcome will be good. So crushing technique is good, you know, but another issue is long-term dual antiplatelet therapy and left main two-stent crushing. Maybe, yeah.
all right.
Yeah, some issue.
He has already deployed the stent.
Yeah, already here.
All
I'm
right.
sorry.
May I
but-
also make some comments?
I actually will undergo the mini crush stent. I also agree with the SK stenting, but I think that the mini crush technique would be better for this patient, the young, constantly young, and the future the prognosis test.
Yeah, may I also make some
I
comments?
have put the 12 millimeter short stent to avoid the OM crossover.
So
And I hope that
3.5 or
3.5. This is 3.5 by 12 millimeter, the giant stent.
Holam, make some comment.
6.
I think for
no,
this
no,
case,
that's
everyone agrees we should go for two stand. And the best technique for me is the operator's choice. If the operator prefer mini crush, then mini crush is the best for this case.
18.
If the operator choose mini crush in
20.
this case, I think there are 3 important points. One is the landing of the side bound stand, the stress stand. What is the exact landing? How long should you pull through out? That is very important in this case, because this come to the second point. Because the left main is very short, you can't do port. So most of the time, you need your kissing to optimize. So the landing of the sidebound stand is very important if you can't do the port. The third important point is you need to choose a stand without force shortening, because while you use 2 big balloons to do the port, in this sort of case, very short left main, and the disease extend to the ostium, then you need a stand with big balloon kissing without force shortening. That's very important in this case.
Would you show us briefly, take a picture first, Dr. Kang? All right, so we're going to show the, the relation with the osti part of the main. Okay, girl. Yeah.
3.5 NC balloon up to the 24 ATM for crushing and pre-dilation of the left main.
So looks like a
And
short
I prepared 3.5 by 23.
All right, very good. Very good angiographic result for LED. We don't need a stand for that.
Yeah.
So this is a very beautiful demonstration, but actually I agree with Dr. Kang in terms of initial thinking about the mini crush, but after actually looking at the first stent deployed in left main to circumflex, it looked as though Q-Lot may have been a very good choice as well.
Because there's some big discrepancy between the proximal circuit to after OM, so he chose 12 millimeter stand. The length between the circle ostium to the OM bifurcation about 10 millimeters on IBUS.
Spider view?
This case, this is a typical crushing, not mini crushing, because the stand is a little bit protruded to the left main, 2 or 3 meters.
More
Yes,
clear.
you're right. I tried to make a nano-crossover like
Yes,
that, but it's
okay.
not easy. Test it?
Contrast test, please, for us. Okay.
Yeah, looks okay.
Point,
but-
okay, 0.5 millimeters. If you want to do test them.
Test it. I will protrude more.
Yeah.
For the pull back, the stand
Protrusion
0.5.
is better than missing.
No.
Test it. Oh,
Wire fix up to the distal part for us.
Probably cranial view is more helpful in this case? Dr. Kang?
This is areocranial.
In this case, I may not rely too much on the view. I will rely more on the stent boost. For example, like this case, I will use caudal view, use stent boost, make sure the AD stent just protrude within 3 mm. That will be more precise because previously your IFAS already marked the length of the left main.
That's a good job. Okay.
Yeah, 3.5 NC, 15mm짜리. After the stenting, I will optimize the main branch stent. This is 3.5, and after 3.5 dilation, I will evaluate with the IVUS. And if there is some malposition or the under expansion, I will use the bigger one because the vessel of the left main was more than 4. Nomina?
What size? 35?
Oh, stop.
No. Okay.
Okay. Nomina?
35 NC? NC below?
Yes, 3.5 NC.
Okay. Up
This
to
vessel was 3.5. So I applied nominal pressure and mid-AD.
what pressure?
It was nominal 12. And the proxy vessel size was 3.7 in IVUS, 20. So I apply higher pressure.
20,
22.
22.
Great. Final balloon diameters?
This balloon, now balloon size is 3.8.
3.8.
3.7, sorry. And we further dilate the left main. 24. 26.
24, 26.
Deflation. Okay. Shall we check angel? Oh, I will show the spider view of the angel.
Angel
It
force?
will be better for visualization. Yeah. Angel, ready? Guiding is not engaged yet, but I'll check the IVUS for left main evaluation.
All right, I think it's good. The proximal part of stand is a little bit, protruding from the main ostial part. However, I think it's a technical point of view is good. No problem.
Dr. Park, how do you think about KBT? KBT, do you do?
KBG?
KBT, final KBT. Maybe everyone want to do, but maybe a little bit difficult, technically difficult to do. The very beautiful KBT.
Okay.
Kissing.
Big vessel, 3-0.
And this is the IVUS pullback from the medial AD after stenting. And this vessel size is same as before. There's a diagonal branch.
Getting bigger.
Will come, here. And stem was placed at the opening of the diagonal branch as intended. Yeah.
Landing is good. Distal.
Maybe, I think maybe a stem would be a little bit protruded at the left main, but I can make it bigger. And proxy fully dilated with a 3.5 NC up to 20 ATM. And here, the circumflex came in from the 9 o'clock. You can see the LAD stent overlapping the circumflex osteo. And left main, it's well placed, I think.
Well, I think it's good. It's a one stand, one stand segment maybe protruding is perfect.
3.5 NC 다시 한번
So,
보세요.
What is next?
So next is that to rewire into the circumflex.
Circumflex.
And we'll open the circumflex osteo and we'll do the final kissing. Because the guiding is not engaged in the left main stent, so I will use balloon again and engage the catheter into the stent and then wire.
Rewiring wire first.
Yeah.
Dr. Kang, would you consider doing port first before your rewiring? Because recently we found that like this sort of situation, if you do port first, then there will be less risk of elongation of stent and also can minimize your risk of wiring under the stent strap.
Actually, I 100% with the opinion, but it will not be part just optimization of the left main. I can use the 4.0, but it's a practical issue. I will use a 3.5 NC in both sides with the kissing, and the lumen will be sufficiently large at the time. So just to save the balloon or some practical issue, I will try with a 3.5, and then if it is not fully dilated, I will use a 4.0. 20?
Because what I see is your landing of the stent
guiding
is
is
perfect
engaged
now.
well. This is why I prefer Joachim for left main stenting. And wire, please.
So rewiring of the circumflex?
Yes, rewiring.
Okay. All right, Dr. Kang, we will be back soon, and so you're going to continue your procedures. And so, okay, Dr. An, Jung-Min An, can you hear me?
Yeah, I can hear you.
Okay, great. We can see. What is your second case?
We are preparing second case. So, Dr. Faisal, could you introduce the patient history?
Good morning, audience, esteemed panelists and chairman. So our patient is a 63-year-old female with a history of dyslipidemia. She was referred with exertional dyspnea. CTCA at another hospital showed proximal LAD and proximal RCA stenosis. Next. She only has a family history of stroke in her father's side, and she has a history, a presenting history of angina classification, function class 2. Next. Her ECG showed normal sinus rhythm. A chest X-ray showed clear lung fields with no cardiomegaly. Next. Her echo showed normal LV systolic function without regional wall motion abnormality. Her coronary angiogram revealed significant stenosis of the proximal RCA and aneurysmal distal left main with a 011 bifurcation lesion involving the proximal LAD and a small ramus intermedius. Next. Her RCA showed a proximal to mid RCA stenosis, which was fixed to the stent just now. Her left coronary angiogram showed a moderate lesion in the circumflex. Next. And her distal left main showed an aneurysm with extension of a disease from the distal left main to the proximal mid LAD. Next. Our target lesion is the distal left main to proximal mid LAD, and we're planning to use IVUS guidance.
So could you show us that the RCA intervention? So Dr. Faisal already implanted the RCA stent. RCA, final RCA, this is already implanted RCA stent, corrected RCA. So the live demonstration only focus on the left main bifurcation.
Good.
Could you show us this is a pictorial view, main shaft to diffuse disease and involved LAD, and some small ramus branch, and some disease in the circumflex. So do you have any comment how to treat this patient?
Okay, I think it's in terms of main, it's a kind of intermediate stenosis. However, we got some IBIS, idea, understanding. It would be some disease over there. And circumflex ostial part, we cannot realize by aneurysmal changes. And so, anyway, depending on IBIS, we're going to make some
could you show us
different
the
decision, right?
Yeah. because of due to the energy change, we cannot see the ostium of a circumflex. So this is a circumflex pullback.
Circumflex first? Okay, great.
Do you have a CT image for this case? We need 3D concept for the aneurysmal dilatation.
Yeah, correct. But anyway, please see the IVUS first. This is the circumflex. The proximal portion of a circumflex, diffuse disease, not that tight.
OM branches? What is that?
Small OM branch.
Look normal size, right?
Yeah. This is the ostium of circumflex.
Huge
Here is
aneurysm.
the huge aneurysm. The LAD wire is coming from the 3 o'clock. Here is distal left main. Lumen is looks like the resolved, but the very diffuse disease. Could you show us the LAD pullback?
Ready? Do you have data about the FFR for circumflex, right?
We didn't measure the circumflex, but the LAD FFR is 0.78.
7.8, right?
Actually, diffuse disease, the proximal LAD.
3.0.
Yeah, 3.0. Diagonal branch coming from the 11.
Look good. Occipital part. Branch is good.
Right.
1, 2, 3, 5. Tightest stenosis.
My concern is the aneurysm are changing. So this is a proximal LAD. Vessel size is 3.0, 3.5, 3.0. Superficial calcification, but the mostly plug looks like the soft plug.
Proximal LAD here?
Yeah, so here is a proximal LAD. The aneurysm is coming from the bottom. Here's the
Big one,
aneurysm.
man. Huge one.
And here is this left main. So circumflex coming from the aneurysm. The ostium of ramus maybe come from the aneurysm. So spider view. So I think I don't care the circumflex and ramus.
So you want to do stent crossover, right?
Yeah, right. So looks
But
ugly, but
if you look at the IVUS findings for upper limb main side, distal shaft actually would be good. However, proximal part of shaft and ostium, they're pretty much plaque over there. So. Okay.
My guiding is a 7 French guiding catheter, so the smaller than guiding catheter left main, so left main definitely is significant. So give me the stent first. So based on the IVUS, the plug looks like very soft. So saving the cost, I'd like to direct a stent implantation. This is what size?
So Dr. Hahn?
3048.
Dr. Hahn, this is Hahn.
Yeah.
So in FFR pullback curve, where is the major step up?
Proximal LAD is a major step. Yeah.
So in IVUS, LAD ostium is relatively preserved.
Yeah, right.
So what about just treat the proximal LAD?
Even though there is a disease in the left main, so give me the high pressure balloon 275.
Anyway, you choose long stenting.
Yeah.
My question was the same. I wanted to learn about distal landing point.
Yeah. 2.5 high pressure. 2.5 just say. So anyway, the 30. If we treated the proximal LAD only, the stent size is around 30. if we recover the left main around the 48, so 10 millimeter difference may not affect the patient long-term outcome. So to cover the whole disease, so I'd like to cover the left main as well. 10.
So when we measure the FFR in that kind of region, tandem region, most ischemic part can be augmented. So if we apply just a stent for the proximal RAD, after stenting, post FFR can be also still lower than 8.0. So it can be issue. So it will be better to cover it from the proximal RAD with left main, I think.
10. Deflation. I fully agree with your opinion. Thank you for a very nice comment. So give me the 3048.
Inflation, deflation looks too rapid, too short to me.
All right.
Yeah, right.
I think it's okay, but Doctor, would you like to consider to use two stand? I mean, separate into two stand rather than just one long stand?
Save the money. Test it. Okay. Test it. Okay. I have to cover the whole.
Or cell part up to cell part. Good. 48 millimeter
Yes.
stent. All right.
Stent.
Right.
Stent
Three
main. Dr. Hahn,
Yes.
what stent? Can you tell us the stent name?
Test again. Test.
Synergy.
Okay.
Test it.
Nowadays, a new stent design has a more expandable for the wrapped main. So yeah, just use one stent and then additional dilation with
Pull
the
out.
NC balloon.
Further.
Test it.
0.5 millimeter.
Test it.
Good.
Multiple projection is very important for left main osteostenting. Test it. Okay. Inflation.
11 nominal.
11.
Nominal 11.
Yeah.
All right.
Take the time.
Oh, you have to wait. Long duration inflation. Oh.
Deflation.
Fast in, fast out, is it?
Professor Hahn suggested me to do the longer inflation time.
I like it.
Okay. 16.
16, 3.27.
16.
In this sort of situation, usually I will do port high pressure on the left main first before high pressure the LAD nowadays. Is for if you use VO, there's a risk of mismatch on the size and the guiding may compress the stent. And recently the paper said if you dilate from LAD to left main, sometimes you will elongate the stent. And then your effort on the multiple view to assess the osteo left main will be in vain.
Zybus.
Good. Perfect.
My concern is left main osteal coverage.
That would be perfect, right? All right.
I hope so. Oh, I think the perfectly, very precisely located. Here.
Okay.
Okay, this is the landing zone. Very normal. Stand this lands on the very normal area.
Perfect.
As I mentioned before, that the landing zone plaque burden is associated with the restenosis rate. Previously, we published data that the stent lands on that the plaque burden more than 50% is associated with the instant restenosis.
Right.
stent is very expanded relatively. The vessel diameter is 3.0. But here,
You did not do high pressure, right?
yeah, right.
Just a normal pressure. However, position-wise is good. Well, positioning. Two, 5.
Using the stem balloon, I applied 18. But actually, stem balloon is not high pressure balloon, so sometimes the final stent size is smaller than the manufacturing chart. Proximal LAD is around 4.0. Here is the individual portion. Here, this left main. This left main is around 4.0.
I think it's almost perfect. So we need that. Ostium?
Yeah. Here is proximal. Here is ostium.
Right, perfect. Right.
Good.
Point. Half segment is protruded out of ostium.
High pressure balloon, 3.5.
3.5?
Okay. Yeah.
All right. Anyways, we've learned just a single stent. Make it simple, right? Aneurysmal changes through looking, through bifurcation, limb main disease. However, if you get some ideas by IVUS or something,
Training.
you can make a very simple procedure.
24.
24?
28. Final balloon size is 3.8.
3.8.
What is this balloon? 28. It seems it's okay.
Right. 16.
3.61.
16. Deflation. 14.
3.56.
14. Deflation.
15,
So
14.
do you have a 3 or something? 3 high pressure? Because the distal portion of stent, the vessel size is around 3.0.
Great.
Okay. Ten.
2.9.
10, 12, 13, 14.
14, 3.03.
Deflation. Test. Okay.
High pressure?
16,
3.06.
18, 20.
20, 3.12.
All right.
Deflation. 24.
24, 3.16.
24. Deflation. Okay. Ready?
Great. Perfect.
Stem looks very fine. The stem, this stem is looks a little bit bigger than vessel, but I was show that very perfect lens. So after I was evaluation finally, and then after taking a coronary angio, and they will finish my procedure. This is IVUS evaluation, final IVUS surveillance.
Do you prepare the another cases?
No.
No. Because we have quite enough time, don't worry.
So, Dr. Han, angiography is very good. Probably IVUS will be also good, but do you consider part in the left main?
After IVUS evaluation, I will consider the additional balloon or not. The IVUS looks fine. I don't do additional balloon for the left main.
You save lots of equipment in this case.
So hands pull back. So look at the left main. So left main diameter is more than 3 ohm. I applied the 3.5 with a high pressure volume up to 28. So very precisely
Good enough.
stand to the left main ostium, cover the left main ostium.
Sure.
So could you show us the left main again? Left main size is not that big. So I applied the 3.5 high pressure volume up to 28. So I don't think we need the additional high pressure dilatation for left main. So
Good.
I don't like to do more parts.
Would you show us spider view and other angiographically? I think it's
So-
perfect. Look at just measure the lumen stent areas in the up there. Stent area, main, something. Perfect. All right. Circumflex ostium is perfect.
Ready? Okay.
Good.
Left main, before treatment, left main size is smaller than guiding catheter. But now guiding catheter easily in and out the left main ostium. So anyway, the left main to the LED stent is very big and well opposed, very expanded. So looking complex coronary anatomy, but using the one stent simple crossover, so we can treat this patient.
Dr. Hahn, you got data about the minimal stent areas in terms of related with the long-term outcomes. So main would be 12 something, 12 millimeter scale?
12
All right.
millimeter square.
However, in many cases, actually, we cannot achieve 12 millimeters, depending on the vessel size, just like particular this case is even in the 4 or 4.5 main size, sometimes some difficulties. And so, how would you get the number of 12 in there?
So actually, the 12 is a median value of a whole study cohort. So 50% of patient more than 12, 50% patient is smaller than 12. But particularly this patient, the left main size is not that big. In this case, we can make a stent bigger and bigger as much as we can, but we can achieve the 12 something.
Right.
But 12 is a kind of benchmarker for optimal stenting. So we can approach to such a number, but we cannot achieve in every patient.
Anyway, the bigger the better, right?
Yeah.
And least limitations, the smallest one less than what number? It's a 9, 8 millimeter scale or something, right?
Smaller than 9, or smaller than 8 sometimes.
All right.
Yeah, particularly the long years ago, the cipher stent era, the biggest cipher stent was the 3.5. Cipher stent expansion was not good, so we included such data. So
Perfect. That's a really, nice case for the make it simple in any way. So aneurysmal changes on then. What do you think, Nakamura? Do you have any?
Yeah, very good case. So actually, if this is in Japan, maybe I think a cardiac surgeon, always complain to us. So this is aneurysmal formation. You should consult us or something. If we can see that some big aneurysmal formation, maybe I think in Japan, if this is in Japan, cardiac surgeon always complain to us. But this is okay. This is okay. This is natural cause.
Very rare cases, and so in fact, we don't have any ideas in terms of
aneurysm,
long-term fate of this kind of aneurysm. However, not pretty much. Dr. Hahn, any comment on that one?
No.
Yeah, the results are very satisfactory. Congratulations, Dr. Hahn.
Okay, so we have enough time, and so you need another cases now. All right. Thank you for
I
your
prepared the
cases,
second
right?
third case.
Dr. Kang, can you hear me?
Yes, I can hear
Do-Yoon
you.
Kang? Okay, so would you explain what you've done?
Yes, this was the last moment, the last scene that I've shown you. And after this, I did the rewiring with the conventional shown wire that was used at the first wiring. Because I fully dilated the side branch stent during the stenting. The rewiring was not difficult and passed well. And after that, I have used the 2.5 pre-used balloon, compliant balloon, with the anchoring at the LAD. So we selected the balloon length to consider the future anchor. At this time, the 50 millimeter was okay. So with the anchor, 2.5 used balloon passed easily. After that, I dilated the 2.5 compliant up to 18 ATM to open the carina. And next. And this is a 3.5 short balloon, 10 millimeter, and passed easily. And applied the 20 ATM to open the circumflex ostium fully. And next. And then sequential high pressure to obtain adequate high minimal stent area at the ostium of the circumflex LAD up to 22 ATM next. And then this is the final kissing with the 3.5 and 3.5. Yeah. Maybe it will make a little bit eccentric the shape of the left main, but let's check in the IVUS next. And previous. Yeah. And after the final kissing and during the retrieving the balloon, you can insert the guiding in very safe manner. Next. And let's check the IVUS. Yeah.
Big main, right?
Yeah. This is a circumflex run.
Rather than we expected, circumflex.
OM branch, just proximal, the stent was placed. Because OM was not closed.
Distal landing is good. Almost more than 3.
Yeah.
Big vessel.
Yes. The vessel is larger than before. It's becoming bigger and bigger during the procedure. But the just ostium is a little bit have the negative remodeling. And here's the carina. And you can see the crushed strut is the very short.
It's a slim main, right?
Yes. And main stent is well placed at the ostium. Right. Can you please show the minimal stent area at the circumflex proximal was 8.3.
Perfect.
In our new cutoff, it was 6.
All right.
And much bigger than that. And can you please show the LAD pullback? We did IVUS pullback from the mid LAD. And as we checked before, the stent was placed just proximal to the diagonal branch. This is also 3.5 NC and applied 3.5 NC with a very high pressure. And I think that the stent is well expanded, fully expanded, and because there was no very severe calcification. And here is the proximal LD. Vessel size is larger than 3.8. And soon the carina comes in. Here is the carina. There's a short carina between circumflex and LAD, and here is the left main.
Big main, right?
Yes, main ostium here. Yeah. And I think the stent is well placed at the ostium. And the minimal stent area at the prox LAD was 10, and left main 16. And in our newly revised data, the circumflex more than 6 and LAD minimal stent area more than 8, if the two are fully dilated, 5-year TLR rate or MACE rate was about 5% only. I think that the patient has the less than 5% TLR rate in the future.
Great. Really, good cases. Big, two stand, very short limb main length. However, you can do the mini crushing. So finally, Nakamura, any comment on that?
Much better than we expected.
Right.
This is very nice result.
Okay. Okay, Dr. Kang, this is a really good case, live demonstration. All right, thank you for that. All right.
Thank you.
Okay. Just, I wanted to get in touch with the China, Shao-Liang Chen. All right. Dr. Chen,
Hey, Dr.
can you hear
Park,
me?
can you hear
Oh,
me clearly?
good to see
Yeah.
you.
Good to see you again.
All
Good
right.
morning. Good morning.
Yes, we have, Dr. Sunao Nakamura. He's a moderator and very famous, interventionist as a panel is in here. So you want to start?
Okay, thank you. So now, Dr. Park, good morning, our friends on the podium. So we are online for a while. So let me introduce my team. Dr. Ye, Dr. Yu, and Dr. Wu, interpreter of intravascular images, Mr. Pan. So let me invite Dr. Ye to introduce the patient case. Go ahead, please, Dr. Ye.
Thanks very much for inviting Nanjing First Hospital for the live case. So this case is a 61 years gentleman with recurrent tightness for 2 months and aggravated for 1 week. So previous history showed he has no myocardial infarction, no cabbage, no PCI procedure, no other medical problem. So he has no diabetes, only has hypertension, no hyperemia, no smoking. Yes, he is a current smoker. I'm sorry. And next, so diagnosis for this admission for our hospital is stable angina pectoris. We checked the echo for the patient that showed that the left ventricle was normal, and we don't check the treadmill test and spectre for the patient. So next. So before he came to our hospital, he showed the stable angina. We checked the angio for him, and 3 weeks ago, the angio previously showed that the right coronary was still not significant stenosis at the distal part, only the mild lesion here. So next. When we check the left coronary artery, we find the severe stenosis at the distal part of the left main. And next. Yes, we can see here from the epicord and the spider view, they showed the severe stenosis at the distal part of the left main, including the ostial LAD and the ostial circumflex. So next, from the aerial cranial, we also find the severe stenosis at the middle part of the LAD. And now the live case brief targeted lesion is this left main bifurcation lesion. And we want to show us, and we want to discuss with a strategy and the tactic for this case with this left main bifurcation lesion with IVUS or OCT guided PCI. So next, if we treat the frequently, we will treat the distal middle LAD lesion. So now we give the patient medical therapy with aspirin and ticagrelor, and we also give the patient with left lower monitor weight heparin before procedure. During the procedure, we give the heparin and showed the ACT was over 370. So now, we discuss a standing tactic for this case, for this distal left main bifurcation lesion with a provisional or two-stand tactic with IVUS guided or OCT guided. That's all for the case. Thank you.
Thank you, Dr. Park. In general, patient is pretty young, 61 years old. 2 risk factors, hypertension and smoking. Left ventricle function is preserved very well. So can we start from the angiography today? So let's go through the angiography from AP caudal. So this is AP caudal.
Previous.
Yeah, AP caudal. This is the San French EBO35 guiding catheter, a little bit dislodgement, but the angio confirmed a very critical lesion in distal left main, involved bifurcated area, also very critical next view. Next. Yeah, from the aerial cranial, you can see downstream very critical lesion in RAD. Probably there is also another bifurcated lesion involving AD and second diagonal. Here is not only bifurcated area, it's a trifurcated area. next, because the distal bifurcation lesion is very too severely, so we use a true semi-compliant balloon to pre-dilate the lesion from right to left main as well from circumflex to left main. After pre-dilation, next we recorded the IVOS from the circumflex, next from right to left main. So now let's invite Mr. Pantao to introduce the IVOS findings from Sir.
Okay, let me show the IVOS imaging. Can you see the IVOS imaging?
Yes, we can clearly see that.
Okay, the first one we check out is from the proximal circumflex to left main. Here we can see the proximal circumflex is not normal, but here this point the plaque area is not very large. And here we can to do the distal Nanjing rule.
Big
Okay,
vessel, right?
here this point here we can see the lumen diameter is about 3.1 millimeter and the vessel diameter about 3.9 millimeter. Then go and probe back, we can see the pier we are drawing circumflex. Here this is the proximal circumflex, and here we can see the calcium. And the calcification angle is about 270 degrees. Then go and pull back. This is the ostium circumflex. And here this point, the ostium circumflex, the area is just 2.1 millimeter square, and the plaque burden is more than 84%. And we measure from the distal Nanjing rule to ostium circumflex, the netness is about 10 millimeter.
So by the way, angiographically, so the circumflex lesion length looks like around 7 to 8 millimeters, very similar to the inclusion for the EBC main trial. But the lesion is very critical in both vessels, and also patient presented unstable angina. So from circumflex IVOS, that is also not severely, but it's a very obvious calcified nodule at the very proximal circumflex. Next, please.
Okay, the second round we check out from the middle LAD to left main. And here in the middle LAD, we can see the calcium, and the calcified angle is about 180 degrees. And then go and pull back. And here, can to do the distal Nanjing rule, and here the
calcified nodule, yes.
Lumen diameter is about 4.0 millimeter. Then go and pull back, we can see the side branch. This is the first diagonal. The first diagonal joining LAD. This is the proximal LAD. The proximal LAD, the vessel diameter is very large. It's about more than 4.5 millimeter. Then go and pull back. This is the ostium LAD. This point, the ostium LAD, the area is just 2.2 millimeter square, and the plaque burden is more than 88%. Then go and pull back. This is the POC. The POC, the calcified angle is more than 270 degrees. Then go and pull back. This is the distal left main. And here, this point is in middle left main. The middle left main is normal, and the middle left main vessel is more than 5.6 millimeter. Then go and pull back. This is the proximal left main. It's normal. We measure from the distal Nanjing rule to ostium LAD, the netness is about 16. And from the distal Nanjing rule to the middle left main, the netness is 26 millimeter. Okay, this is a baseline IVOS imaging.
So in general, the reference vessel diameter is 30 for circumflex, but it's 40 for proximal LAD. Also from the epicaudal, combined with the IVOS finding, there is a very severe calcification from proximal LAD to the distal left main. Both the IVOS image from SIR and from LAD confirm the presence of calcified nodule. So I think this we just work here. So any comments and suggestion from panelists?
Okay, so we.
So first of all, Shao-Liang.
Hi.
Hi,
Sunao.
I'm Sunao. Yeah. So how do you think about the region preparation in this region? So it looks like, of course, you use a smaller balloon dilatation, pre-dilatation. But just I have a question to you about the lesion preparation in this region. Of course, some not so beautiful location with the calcification. So I guess a little bit for me.
Thank you very much.
Yeah.
Thank you very much. Snore. Preparation using relative small balloon is actually not going for real preparation. It's just to allow the recording of IVOS image. That's all. And I think because the live transmission time is very limited, only 30 minutes is the right dot park. So I think we need to focus on the discussion of standing strategy. So if we go through from provisional standing technique, so I think we need to very carefully modify the lesion from right to left man. If we go through from upfront to stand technique, so I think we also need to prepare lesions, but I think two stand technique will be easy to keep both vessel pattern. So anyhow, so what's your comment and suggestion?
Okay, why not? So want to do in terms of how to treat concern. Any comment on that? Oh, Lam.
Professor Chen, this Lamho, I think in this case I will choose DK crush. I won't choose provisional because the risk of shirt closure is very high. The reason to choose DK crush is because the shirt ostium actually is ambiguous. You cannot 100% confirm where is the ostium. The most safe way is still DK crush to ensure the stent have full coverage on the ostial shirt. Regarding the preparation for left main, I think maybe balloon is still okay. However, from the distal AD to the proximal AD, probably you need water basin. In this case, I will do the shirt and kissing and high pressure, and then see angiogram and then review.
So Dr. Chen, would you gonna do DK cross systems?
Already.
Yeah, actually, I planned to use the DK quality technique, even according to our definition criteria. So the circumflex lesion length, it looks like shorter than 10 millimeters, but because of the very critical lesion in the distal left member Vulcan lesion. So I'm using DK. Okay, I think this is take photo. Okay, so if you can see the angio, so 30 by 13 stand in the circumflex and another 4 balloon in the RD to left man. I need to little bit put distally the 4 stand into the RD test. Also, okay, one more test. Okay, I think this is a good position, inflation. So according to the IVOS, so the distal landing zone down. So the distal landing zone for circumflex scan could be very close to the taking-off point of small obtuse marginal.
14.
Okay, done. So usually right now, immediately after standing side branch, because of the presence of another small branch taken from circumflex, we can use either the stem balloon or another NC balloon to modify the side stem. So after deployment of side stem, I slightly withdraw the stem balloon to modify the side stem. I think now we can take a photo. Go ahead. So to see, I think the circumflex looks good, but they also show LAD much more compromised. But don't worry. So I think this is one of the beauties by DK quality technique, which always keeps the both vessel patterned. So this is a 4O balloon in the LAD test, small test. Okay, inflation by 6. So I think this is not to go to complete the crash, 6, 8. Okay, done. So even there is a very severe calcification as a proximal ID, but 4 balloon angio. So the full balloon, no.
Go back.
So full balloon could be expanded very good. Can you see that, Joe? So now I think this is not real force balloon crash type photo. I will show you the immediate finding. So right now I think the blood flow in Artery flash is good. Patient does not have any chest pain or any sign.
Yeah.
No change EKG and blood pressure. Because according to the IWAS, the proximal ID is about 5.6 millimeters. So I need to use another 5.0 pod balloon to do real force balloon crash.
Professor Chen, there are always two schools of thoughts. Someone said that we can keep the wire in the side branch while we do the stand crush. Some said we can't. In your case, is it a wire rewire or just the original thread wire?
Yeah, actually, before balloon crash, usually I do not remove the wire from the flash because there is no any concern about the stacking of side branch wire by balloon. After first balloon crash, if we need to use a third wire, so the gelled wire in side branch could function as a roadmap to guide the rewiring, the crossing position. So we finished the balloon crash using 4.0, but it's undersized for left main. So right now, no. So this is a 4.0 by 6 or 8. 4.0. Balloon length. Length 6. Okay, so this is a 4.0 by 6. It's a dedicated
very
type photo.
Short balloon,
This is
right?
yeah, very short. This is dedicated balloon only for balloon crash for pod technique. So inflation go ahead. 6 study from 6. This is an NC balloon done. It's very sleepy.
This balloon is very good. I see the shoulder is very short. I think this balloon may be with some specific design. We don't have this in Hong Kong.
Yeah. Test one more test. Okay. Let's start from 4.
Fasting.
4, 6. 6. I think it's a good position. Can you see Andrew? 6, 8. 8. So right now balloon was not fully panded. So now it's fully panded. So I think it's good to achieve the complete balloon crash. Andrew again. Okay, good. So now I think we can have 2 ways to rewire. First, using the gelled wire. The second, to use the third wire.
Rewire for circumflex, so?
Yes.
So why do you focus on the short length of balloon, 6 millimeter?
Yeah, because the proximal ID is only 4 by 2. It's greater than 5 millimeter for deuce left main. Okay. If the balloon too long, so I think there will be high risk of dissection or even perforation for proximal ID. Otherwise, if we use a full balloon, it could be much longer. Yes. So another story is that immediately after balloon crash, if the wire from the right position, there will be no any resistance. So I can remove the gelled wire. Which one is the gelled wire?
Yes, this one.
This one is gelled wire. So now I have removed the gelled wire, and like to take a photo to show the rewiring position. I think it's a very good position. From angle, I think it's a cross the side stand from the proximal cell. So 先给我这个 30 NC balloon. So right now, so Dr. Park, do you have any Any comment or suggestion for the remaining steps of
Anyways,
DK crush?
we've learned, in detail in terms of DK crushings, as explained a little more step by step. And 2-wire and the kissing balloon after.
Right.
You're gonna do the kissing balloon inflation. 3030.
Yes.
Right.
Yes. So can you see, Angel? So it's very easily to get the 3 balloon into the sync flash. So 3-0 in sync flash, another 4-0 in the RAD to left main. So usually, we don't need to use a stepwise inflation to get the before the kissing balloon inflation, because if rewiring is correct, so I think it will be easy to get the side branch balloon in. So once the side balloon in the position, so I think where is the RAD balloon?
Stay in the cast.
Okay,
Yes.
RAD balloon. Okay, so I think this is a good position.
Perfect.
A little bit small photo. So from the angle, you can see the overlapping of 2 balloons in the left main is too long. According to my personal experience, so I think it's not good. So I need to slightly to push 2 balloons into the 2 vessels a little bit. Which one is sync flash? This is sync flash. Okay.
Yes.
Sync flash. This is the RAD. So I tried to make sure the overlapping of 2 balloons as short as possible. So inflation from sync flash.
Sure.
So before each kissing balloon inflation, we always perform sequential inflation study 16.
Yes, 16.
From side branch to left to main vessel. This is the AD balloon.
Yeah.
Okay, inflation. So right now is a turn for 4 balloon from right to left main down.
Sequential dilation, circumflex AD,
Right.
and then final kissing, you mean? Okay, good.
Right. This is final kissing. 6. Go to 6. 10 for sync flash.
Yeah.
Yeah. So
slip down.
So a little bit sleepy for RAD balloon, but it's done the match. Because for kissing balloon inflation, we don't want to inflate 2 balloons at a very high pressure to minimize, to avoid any intraprocedural complications. So once we have finished the first kissing balloon inflation, 4-0 by 26 then. So I'd like to take one more photo for you. Okay. So that looks good. Any suggestion from the angiography? Dr. Parks? No?
Just we enjoy your procedure. You are the origin.
Oh, thank you. Thank you. So I think we can finish our job before 11:20. Still 10 more minutes left.
Okay, no problems. We have enough time.
Once it stands in its position, I will remove the side branch wire. A wire.
What size?
Take out wire.
What size of stand? Length stand?
Yes. Good. I think this position. Take photo. No. Take photo.
All right. Before the
Yeah,
inside.
because of the diffuse lesion from the proximal ID to very distal. So I think the distal landing zone is very important. According to that, I was finding. So the landing zone for proximal ID lesion could be just before the taking off of a small branch, a little bit distal.
Yes.
Test. Okay, test.
Shin.
Okay,
Sorry.
I think this is good. Infection from 6. This is a 4 by 26.
6.
This is a, what's this then? It's a
Resolute.
8.
8. Integrity.
Integrity. This is integrity. Done. Because this is a full integrity stent. And from baseline I was finding, so the left main reference vessel diameter is greater than 5.5. So full integrity stent could be expanded up to 5 or 5.2. If too much higher inflation, I think it will be easy to get stent fracture. Okay, photo, take a photo. Good.
Great. Nice.
Yeah, I need to use a full ONC balloon and followed by a pop balloon to do real pop. Also, you know, from angio, can you back to the angio? Go back.
Yes.
Yeah, so you can you see slightly gap between a short distance between the proximal stent edge to the orifice of left main. So I think in this particular situation, so I think a pop balloon will be much better to perform the proximal optimization.
For
this is for
yeah.
Okay. Hopefully I can have at least 5 minutes to record the IWAS image from both flash and from AD to left main. Okay. So the guiding catheter is much better. So I think we can start from here to post 12, just 12.
Okay, 12.
So this is a full NC balloon, fully expanded. Can you ask the patient if there is any complication? 14, 16.
16, yeah.
Okay, very good, done. Yeah, also we can, okay, one more inflation, 16, 5 pop balloon.
16.
18.
18.
18, done. Okay. So usually I think this is a typical case, typical representative of a patient with a very complex lesion, multi-vessel disease in our Asian countries. In Western country, I trust the patient will be delivered to cardiac surgeons. So Dr. Park, do you have any comment about the difference between PCI and the cabbage for such kind of patient and lesions?
Right. All right. Particular this case is, I think, is a really good candidate for PCI, right? No doubt about that. And so, however, still we have a long way to go in the different country, different operators, different way of thinking. So, all right. And as a next step, you want to do wire for the circumflex?
No, not yet. We just post dilate using full balloon. It's exercise for
kind of part.
So right now, I'm using 5-0 NC balloon in flash.
5-0? Big
yeah,
balloon.
This is the pop balloon.
Big balloon, right?
Yeah. POT balloon. It's an amazing balloon. Small test. Okay, inflation. 18. 20. Yeah.
Balloon, right?
Yeah.
Looks good.
Is
Looks
more,
much better.
more powerful?
Small test. Okay. Yeah, one more port. Go ahead. 20. 20. Done.
Pretty.
I think this pop balloon is fantastic because the soda is very short. Especially if we use it to do the final port, then the chance to damage the metallic carina will be less.
So this is the final image of the port for left main stent. That looks very good. Full stent from the proximal ID is fully expanded. So from angio, we could not see any stocking, any slowing blood flow in the left main. It could be another sign of a fully expanded stent in the left main. So next step is to rewire into the Seung-Jung. So after port, So the oxygen synthesis looks like more severely compromised. So I need to a little bit reshape the distal wire. So I think the remaining steps are very simple. If no time, we can stop our transmission from
No
distal.
problem. Right.
Thank you. Oh, okay. So I think this is a final step for me to rewire into the second flash test.
Very easier, right?
Yeah.
Easy
Yeah, very
to
easy.
pass the wire. That is,
Yeah.
advantage of a TK crusher, right?
Yeah.
Right. After
Yes.
pod.
Yeah, you
Kissing
see from, I think from proximal to middle cell, no any resistance. I still like to use the 3O NC balloon. Previously used, reuse the NC balloon.
Okay.
3O.
3O. It's coming.
3O. 3O NC balloon. Yeah, 4 balloon.
4.
3O for circumflex and 4 for LAD, right?
Right. Because the side branch balloon size is pretty small. I mean, 1 millimeter difference between members of side branch.
Sure.
So I think the alternative inflation between kissing balloon inflation is very, very important. For by alternative inflation, by sequential inflation, I think side branch balloon inflation could get could push forward the side scan strap very tightly with the carina. So once we finish the final kissing balloon inflation, so you see, can you see, Angel? So very easy to get balloon into the second flash. Okay, 4O. So now the 3 balloon in the second flash. I'm also using the reused 4O balloon for RAD to left main. So I think this is a good position. Where is the 4O balloon? But today, Dr. Parker, you say the image is not good. So can you see Angel very clearly?
No, it's coming.
Okay, 3O inflation. 3O.
3O.
3O. 14, 16.
16.
Yeah, 16. 18. Done. Okay, after sequential inflection from the flash, next step is for 4O balloon. 6.
High pressure.
10. 12.
12.
Done. Okay. So after sequential inflation, so final step is the kissing. Also from 6, both 6, 12 for single flash, 10 for RAD, done. Okay. So I think the pattern of kissing balloon inflation looks like a very beautiful. It means a very short overlapping in the left main around the POC area, and the 2 balloons are fully expanded. So now I think we can remove the balloon, both balloons, and we'll recheck the IOS, then finish the procedure. This is a synflex balloon.
Perfect.
So thank you, Dr. Park. I think I personally have no more time to go forward with you, as I have another live transmission. So I will record the IOS image from RAD to left main. Then I have
Anyway,
to
so
leave.
we're gonna see the angiogram first, and then.
Yeah, Angel, go ahead.
Ooh.
Good.
Great.
I think it's
It's almost
much
perfect.
better.
Would you show us? Would you show us a spider view?
Okay,
Chen?
I will do.
All right, so we're gonna see. Oh, great.
Okay, photo.
Yeah.
Perfect.
I think.
All right, right.
Perfect. So
Okay, really you belong, in detail in terms of DK crushing. So it's a really good angiographic result here. So Dr. Shao-Liang Chen really, all right, thank you for
okay.
your nice
Now,
presentation.
can you see I was image of the park?
All right.
From this age.
All right.
This already.
Okay, why not? You want to do IBIS?
Yes.
Okay.
Can you see I was image?
Would you show us that?
Check to the main screen.
Okay, perfect.
Okay. That's enough. I think the display, this stand is expanded very well. Almost 1, 2, 3, almost 3.75 in diameter. It's good enough because I could not use high pressure to push that this stand.
Well,
so here I think it's very close to the proximal. Looks like 1, 2, 3, 4, 4, 0. So it's fully expanded. So very close to the carina. So sun flash is very close. Sun flash.
Left man.
Okay, here is a POC area, I think.
Yeah, the middle left.
Yeah, no stance fracture.
Yes.
So almost 50 millimeter in left man, 1, 2, 3, 4, 5 millimeter. Big enough. I think it's big enough.
Right. Big enough.
Yeah, it's out of stand, right? Posture left man is normal. So, Dr. Park, thank you. Once again, thank you very much.
Really great cases, right? Big enough. It's a big vessel.
Thank you. My colleague will record our image from Central Flash.
All right.
And I apologize for early leaving.
No,
I'm sorry. Thank you, all
all
friends.
right.
See
It's
you
great.
next week in Nanjing.
Thank you for joining us. It's really
Thank
great
you.
cases for us. All right. Thank you.
So the lecture, we will now start the lecture, Advanced Technique of Sidearm Protection in a Bifurcation PCI. The Scott Harding, please.
Thank you very much. So it's pleasant to be giving this lecture on advanced techniques in side branch protection for bifurcation PCI. I do have some disclosures. So we've seen this morning that a provisional approach remains a mainstay for bifurcation lesions. Unfortunately, sometimes when we use a provisional approach, we can compromise the side branch or we can lose the side branch. And we know that that is associated with periprocedural myocardial infarction and associated with adverse long-term outcomes. So how do we assess where we're likely to lose the side branch or not? Well, we all know the angiographic features. Essentially, if we have a true bifurcation that's severe, if we have severe disease in the side branch, if there's an unfavorable side branch angle, it predicts that we're more likely to lose the side branch. But as we've seen this morning, the problem with angiography is it really doesn't display bifurcation anatomy. And we really need intravascular imaging to understand the bifurcation clearly. And certainly my preference is OCT for most bifurcations because it gives us far more detail. Now, there have been a number of studies which have looked at features that predict side branch compromise for OCT. So if we have a small crinotip angle, if we have a small distance between the crinotip and the emerging point of the side branch, if we have calcium opposite the side branch, then we're much more likely to get side branch occlusion through carina shift. Also, if we have a lot of lipid around the side branch, we'll also have increased risk of side branch occlusion. So I guess the question is, if we can identify this, what can we do about it? Well, we know from studies that just simply putting a wire down the side branch will reduce the risk of occlusion. And that's the bare minimum that we should do. Obviously, if we have a very large, important side branch and there's a high risk of occlusion, maybe we want to start with a two-stent strategy. But in some cases, the side branch is not suitable for that. And I'll show you some cases that will illustrate some techniques that we might consider using. So here's a case. This is a patient who presented with inferior MI, had a VFRS complicating that, had a PCI to RCA and circumflex, and then got referred for a staged PCI to LAD. The LAD was ischemic in the mid-vessel with a RFR of 0.83. And you can see this is diagonal, which is small, diffusely diseased. But actually, if you look, the area subtended by this diagonal is not small. And the problem with this is that we don't want to lose it. Why don't we want to lose it? Because the patient's highly likely to be symptomatic, likely to have a periprocedural infarct. We won't be able to discharge them from a hospital, or be delayed. It may not have a long-term prognostic effect, but certainly it'd be better not to lose it. So what can we do? Again, if we look at the OCT, there are features that predict that we're highly likely to lose the side branch. There's a large amount of lipid. If you look at the right upper panel, the blue outlines the lipid, and there's significant disease in the side branch, which is highlighted in the white. Not only that, is that we have a very small coronary angle. All these features say that we're likely to lose the side branch. So we use the retained microcatheter, and effectively what this does is provides a physical barrier against coronary shift or plaque shift. We stent over that. We do our post-dilation of the distal and across the bifurcation while that is in. And then you remove it, and then you do your pot. And this is the final result. So the 17th EBC consensus document was dedicated a lot to advanced side branch protection techniques. And if you haven't read it, I suggest that you do. So the gel microcatheter technique is one of these. The gel balloon technique is something we use far more often, mainly because it's as effective and a lot cheaper. There are some other modifications of techniques, and I'll show you some of these in the next case. So here's another case, another LAD, and you can see there's two diagonals involved in this lesion. The lesion's pre-dilated with a 2.0 balloon. We do OCT. And again, the OCT shows a very large lipid pool around the bifurcation and a very short length between the coronary tip and the emerging point. Again, this predicts that we are highly likely to have compromise. And you also would have been aware that proximal diagonal actually had a very unfavorable angle for wiring. So in fact, it was very difficult to wire up front, and we actually had to use reverse wiring to wire the proximal branch. And so if that branch had been occluded, there's no way we were going to be able to wire it. So once we'd wired both branches, we can pre-dilate in the main branch. And then we use a jail balloon technique. So this is a 1.5/15 in the proximal of those two diagonals. Stents put in, we post-dilate distally and across the bifurcation. Actually, once we're post-dilated, we had no flow and the patient had chest pain and ST elevation. So we inflated the jailed balloon. And what we end up doing is what we call an external kiss. So we inflate the jail balloon, which is external to the stent, and also the balloon within the stent, because it minimizes the deformation of the stent. We then go ahead and perform pot, so we carefully try and avoid going across the side branch. We did pot, but unfortunately after pot, we lost flow in the side branch, and the patient got chest pain and ST elevation in the lateral ends yet again. So what can we do? Because our wire is outside, and we don't have a wire through the stent into the side branch. So this is time for the rescue balloon. So this is a 1.5 balloon that's coming down over the jailed wire behind the stent. You can see it actually passes quite easily. We then inflate that. We repeat the external kiss, and we restore flow to the side branch. And just to show you that after this, you can see a little bit of deformation. It's probably easier to see in the 3D reconstruction, but the amount of deformation is not as much as you would think. We use the pot to correct that, and that's the final OCT showing that we've got a very nice result in the main branch and preserved flow in these diagonals. Final angiogram. So there is some data that suggests that a jail balloon may be better than a jailed side branch, jailed wire in the side branch. So I'll conclude by saying provisional stent is still the mainstay of bifurcation PCI, but side branch occlusion can be a problem, and we can use angiographic and particularly intravascular imaging to predict that. And if we predict there's a high risk, there is some advanced side branch techniques we can use to prevent occlusion. Thank you.
Great. We're going to discuss in the later. And the last, Michael Lee will give us a treatment of a calcified left main coronary artery disease.
Great, thank you.
Dr. Lee, please.
The failure to appropriately and adequately treat severe calcium can have deadly consequences. This is an 80-year-old male who had an ACS. As you can see, this operator decided just to do plain old balloon angioplasty for pre-dilatation. But when they tried to do balloon dilatation, the lesion would not yield. Required multiple balloon inflations. If you look very carefully, there's some staining in the prox LAD. Slow flow ischemia, contrast dissection. Patient had cardiac arrest. Required ECMO, Impella, subsequently was stabilized, rotational atherectomy. You think about Andreas Gruntig 45 years ago, realized that calcium was the enemy. This is one patient who underwent rotational atherectomy for left main disease. You can see had severe PAD, had mesenteric stenting, an osteal left main, prox LAD, a subtotal left circumflex with a dominant distribution. Surgery was not an option because had severe bronchiectasis, was not a good surgical candidate. We decided to do rotational atherectomy. You can see here it's a long diffuse LAD and involved the ostium of the circumflex. One of the disadvantages of rotational atherectomy is that it requires stepwise increase in burr size. So you're not going to use a 175 burr to start off with a subtotal lesion. So we started off with a 125, slowly, progressively increase the size in a patient with an ejection fraction of 15%. Ultimately, the final burr size was 175. Plaque modification, we pre-dilated the LAD proximally, put in a 3.5 millimeter stent. Then we started to address the proximal circumflex with a crush technique. Afterwards, we put the prox LAD stent in, and we're going to place this in the ostium of the left main in the LAO cranial projection. We did a pot and flaring of the ostium of the left main. Final kiss, and this is your final angiographic result. The patient did fine, lived another 5 years for an 80-year-old female with severe bronchiectasis and was not an operative candidate. Another possible atherectomy device is orbital atherectomy. And this is my preferred device because, unlike the previous case where we had to stepwise increase the size of the burr, this basically is one size crown. So from going from low speed to high speed, you go from 125 diameter, similar to a rotational atherectomy burr, to a 175 rotational atherectomy burr. In this cartoon, or this slide here, actually really describes what the benefit of orbital atherectomy does. If you look here at the greater curvature of rotational atherectomy, it really has contact here only at the greater curvature, but does not affect the lower curvature or lesser curvature. With orbital atherectomy, not only does it rotate, it orbits, so it has complete circumferential contact with the vessel. Therefore, you're going to have more plaque modification and debulking. This is 3-year data from the Orbit 2 trial, which was a seminal trial which led to the approval in the United States with orbital atherectomy. This is 3-year data, and the TLR in complex calcified lesions was only 7.8%. In real-world data, we combined our data with 2 New York centers. We had 458 patients. Angiographic complications were low, less than 1% risk of perforation, dissection, no reflow. If you look at 1-year data, 12.6% MACE, mainly driven by target lesion revascularization in complex lesions. This is one case where orbital atherectomy was applied. This is a 68-year-old male with a history of idiopathic pulmonary fibrosis, was not a surgical candidate because of lung disease, was being evaluated for a lung transplant, saw left main disease, long diffuse LAD disease. So we decided to treat this patient with calcified left main disease with orbital atherectomy. And this procedure itself is actually quite simple. It just, all you do is turn the device on, you go back and forth. I think it has less hemodynamic embarrassment compared to rotational atherectomy because you're less likely to have distal embolization and have any hemodynamic embarrassment. So when you orbit, you, I think, preserve flow and you're less likely to have any hemodynamic compromise. So here are the final angiographic results. The ostium of the circumflex was reassessed with FFR and it was not ischemic. One new device that's been introduced is intravascular lithotripsy. This really has been, quote unquote, a disruptor in the field of rotational with plaque modification. This is a patient with severe PAD, had severe CAD, cardiomyopathy, ejection fraction 30%. Mechanical circulatory support device was not an option. You can see the distal left main is involved. We did a viability study, and the distal LAD territory was non-viable, so we decided not to treat the distal LAD. We also had circumflex involvement as well. Clearly, surgery is not an option for this patient. So we decided to use IVL, and this uses acoustic pressure waves, which are emitted from these emitters. And in this slide right here, what it shows is that these acoustic pressure waves cause little micro explosions. So this is on gypsum. So it cracks the gypsum, but on fingers, you could put your finger there and it's atraumatic. So it's hard on hard, soft on soft. It has, in theory, less risk of perforation because you're not having a drill spin 120,000 times a minute. Less risk of distal embolization. You're not going to have plaque going downstream. All it does is cause calcium fractures. So we try to use just a plain old balloon to pre-dilate. A 3.0 balloon would not pre-dilate. This is a peripheral shockwave device prior to the introduction of the coronary device. So this is a 40 millimeter, 3 millimeter diameter balloon inflated at 4 atmospheres. At 4 atmospheres, it was able to completely profile in a balloon previously that did not completely profile. So this is here, the left main stent going in. This is final kissing balloons. And here's your final angiographic result. Data with left main with IVL is limited. This is only one study of 31 patients, 30-day follow-up. One patient had a MACE that was driven by MI. So we decided to convene the principal investigators of Disrupt 1 through 3, and obviously the leaders of left main PCI, including SJ and Deok-gu Park. And we thought the left main IVL was a very reasonable option, a safe option with patients with severe calcified disease. So in conclusion, the treatment of calcified left main disease is complex. Oftentimes you need plaque modification to achieve optimal outcomes. IVL appears to be a safe, reasonable, viable option, but ultimately more data, more studies are need to determine the safety of this treatment. Thank you so much.
All right, thank you. Actually, so we are, very limited time, so we want to move short the live session. Anyway, good lectures and good discussion and very excellent live case demonstration. Thank you for all, right? Thank you.
Let's get it again.